Welcome, everybody. It's nice to see so many familiar and new names coming onto this webinar. I'm just going to chit chat for a little bit because we had over 300 people sign up for this webinar. I want to give everyone's internet chance to connect with us. So hang out and listen to the boppy music. And we will get started in just maybe, I'm going to give it 60 seconds only because we got people coming in. It's nice to see so many familiar names. All right. This is wonderful. Terrific. Welcome, everyone. Thank you for joining us today. Because we have a large volume of folks who have signed up for this webinar and are attending this webinar, we've limited some features on the platform so that the AV interruptions are minimized and that we can spotlight the panelists. So as you're getting familiar with the controls, you'll notice that only panelists and moderators videos will be available. Your video and your mics are muted. And we've disabled chat for attendees, but we encourage you to submit questions through the Q&A feature, which my colleague Jess will be monitoring. Obviously, we'll also be saving time towards the end of the event for Q&A with the panelists, and we'll elevate your questions then. So feel free to type them into the Q&A panel throughout this conversation. We'll do our best to answer your questions now, or we'll follow with you afterwards if we have. We'll also be sharing resources through the chat and Q&A, so you can also stay tuned and look at that. I'm Miriam Young. I am your facilitator moderator for this amazing panel. I have been a consultant with the Free the Pill campaign for the last 4 years. And prior to that, I was the executive director of a national organization that was a coalition member of the Free the Pill campaign. So I've been involved and engaged for, maybe 9 years or so in this process. And I'm really thrilled to bring so many friends and wonderful colleagues and activists and fierce warriors to this webinar to really think and dive into the conversation about how would an OCOTC impact Black women in particular. As we near the end of Black History Month, I thought this was apropos. So thank you, Dr. Villanueva and Jan and Victoria, for making yourselves available for this conversation. This webinar is a public event for public purposes of educating and engaging audiences about birth control pills and the coalition-led efforts to make them over the counter in the US. This webinar is a product of the Free the Pill campaign, which is a project of IBIS Reproductive Health. Here's the disclaimer. The content, remarks, and materials included in the recording may not be edited or altered without the permission of Free the Pill. If you are a reporter, which we hope you are, and are interested about writing about this topic or using any of this material, which we hope you are, please reach out to our comms people at Conway Strategic. Okay, just another note before I introduce our panelists through their bios. Monica Simpson had some unexpected travel come up in the last minute, so unfortunately she will not be joining us, but we will all channel Monica's wonderful spirit and wisdom, and certainly talk about Sister Song's longtime contributions to these efforts. So today, who we do have are Dr. Rachel Villanueva, who is a women health expert and advocate who's committed to reproductive justice, health equity, workforce diversity, and disease prevention. Having served as the chair of the board and speaker of the House of Delegates, she is now the 122nd president of the National Medical Association, the nation's oldest and largest professional organization representing African-American physicians and their patients. She is the first former president of the Student National Medical Association to become president of the National Medical Association. She also, by wild coincidence, happens to be my OBGYN. Who knew I had a doctor of the stars? I feel extra special. So this is a extra special professional and personal welcome to you, Dr. Villanueva, for joining us.
Thank you for having me.
Yeah, we also are joined by a good friend. Jan Robinson Flint holds the executive director position of Black Women for Wellness, a women-centered community-based organization working on reproductive justice issues as they impact Black women and girls. Jan is also part of the Los Angeles Coalition for Reproductive Justice, California Coalition for Reproductive Freedom, and In Our Own Voice, National Black Women's Reproductive Justice Agenda, with the intention of lifting the experiences and voices of Black women in pursuit of health and well-being. Jan is also one of the funniest and most honest people I know, so really thrilled to share space with you, if even only virtually. Hey, Jan.
Hello, Miriam.
And last but not least is Victoria Nichols, who joined the IBIS Reproductive Health Group in 2021 as the new fantastic project director of Free the Pill, which is our campaign to educate and engage the public in support of an over-the-counter birth control option in the US. And in this role, she works closely with team members and partners to develop and integrate all the comms, all the field work, all the policy, all the advocacy, all the research, and all the regulatory strategies that flow into this campaign that we've been developing for over 15 years. So throughout her career, Victoria has worked to support mission-driven nonprofit and philanthropic organizations to improve policies, practices, and systems that fall short of addressing the needs of diverse communities. So joining us from the wonderful town of Los Angeles, our very own project director, Victoria Nichols.
Hi, everyone. Good to be here.
All righty. So let's jump into it. And I am right on time. I love it when everything works out so far. And I want to actually direct the first question to Jan, as someone who's been engaged in the working group and the Free the Pill campaign for a long time. But to kind of set the context and the groundwork, what does reproductive justice mean to you and to us? And tell me historically, how have Black women held so many of the contradictions around contraception and reproductive freedom or reproductive choice and on autonomy?
So that's a lot of questions boiled into one.
It is.
It's a lot. So, and I actually wanted to reflect on something that you just said also, that we have been talking about Free the Pill. And with Free the Pill, what we're talking about is creating access to birth control pills so women can get them over the counter, and that they won't have to set up a series of doctor's appointments to get something that they feel like they need at that point in time. But we've been working on this for 15 years. There are women who have been born now who need those that weren't around when we started this work, and looking at how medical technology should have advanced in 15 years, given the knowledge that we have now and the minds that we have working on it. So I just wanted to make that note, 15 years is a long time to work on something, to work on creating access to something so fundamental to women's lives, i.e. the ability to control when they get pregnant and if they get pregnant. So, and that's one of the fundamental principles of reproductive justice, right? To control our own reproduction, to make a decision about if we want to be pregnant and when, to be able to raise our children if we decide we wanted to be pregnant, and to have the resources and information we need to make those decisions. So that's reproductive justice, right? In a nutshell. There are a lot of tenets around that. Because we use the word justice, we're really talking about all those intersecting issues that influence and impact our decision to reproduce or not, right? So that term reproductive justice was coined, I'm feeling about 30 years ago. I'm gonna have to, start getting real edgy with numbers because I'm sensitive about my age and how long we have been working on this. But it came from when Black women attended a conference in Cairo. And it was a conference on population and quote population control, and came back from that conference and said that conference was not about us being Black women, not about us looking at the threats, and I use that word threats, to our reproductive freedom here in the US and worldwide, right? If we weren't looking at the social determinants that influence our decision making, we weren't looking at the racism. We weren't even looking at the racism inside of the reproductive health and rights movement at that point in time, which is where we got to reproductive justice, to say we need to deconstruct this and talk about that Black women, yes, we want access to abortion, but yes, we want to have children when we make that decision also, and not be put our lives and our children's lives at danger or in threat. Right now in the US, Black women are 246% more likely to die giving birth or after birth. That's ridiculous. Black infants are more likely to die in their first year. We have numbers comparable to developing countries, right? So we were looking at the entire picture, right? How to have children, how to make a decision not to have children, and how to raise our children. I don't have to tell anyone on this panel, and probably anyone in this audience, how every week we turn on the television or the news, and there's another Black child killed by the police, by a no-knock warrant, etc. If we have children, we want to be able to raise them and see them live and thrive. So is there a contradiction to us around birth control, family planning? No. Black women have always wanted to control our fertility. We have always wanted to control whether and when we have children. When I think about history, I think about one of the first women pharaohs in Kemet or Egypt, Hatshepsut, sent out, she was like, look, we got to get this birth control under control. So we're talking thousands of years ago when Black women who were stepping into leadership were saying, we got to work on the birth control, right? What we have a problem with is being used as guinea pigs and experimentation around birth control and family planning. We have a problem with J. Marion Sims, just vast experimentation on Black women. We have a problem with folks going to Haiti or Senegal or Puerto Rico and using women to test out birth control methods and challenges. That's where we have a problem. So no, we don't have a problem with controlling our bodies, with bodily autonomy, with self-determination. What we had a problem with it being used as experimentation.
Right on. I really love the your framing and over saying it's our choice, and it's our desires and our needs and our choices. And thank you for lifting up the history. We always acknowledge at these webinars the sacrifices and the history of experimentation on women of color, particularly Puerto Rican women, in the development of the birth control pill. And you're exactly right. Those are problematic. So we owe them a debt of gratitude. So given that, in some ways the development of contraception and the reasons why some people may support contraception, AKA population control, right? Like, what made this OC-OTC working group and what made this Free the Pill campaign different so that Black Women for Wellness has been part of our efforts for so long? Why are you part of the OC-OTC working group?
So we're talking history again.
Yes, a little bit.
A year and 15 years of history. So what we are trying to do Black Women for Wellness is to increase our options, increase access, and increase resources for Black women to be able to make their decisions, right? Yeah. And that's what we're trying to do. So for women to be able to get a pill over the counter increases our options, right? And it increases access, right? There was an establishment, I'm going to use that word, in Los Angeles called The Well. And The Well was a collaboration, and one of the organizations that was collaborating at that point was California Black Women's Health Project. And I was part of that organization at that time. And they were like, we're going to give out pills at The Well, which was not a health center. It was a center where women could go to get help, to get healing and well-being, etc. So I was like, whoa, wait a minute. What do you mean? We're handing out birth control pills? And they were like, they're safe, right? And what we're doing is we're helping women control and make decisions about their reproductive health. And when they need to, as opposed to deciding, okay, I need birth control, let me get an appointment. If I have health insurance, if I don't have health insurance, let me figure out how to get health insurance, and then let me get a prescription and all of that. And their position was, let's give women the pills, they're safe, and we'll make an appointment so they can get in. But while they are making that, generally speaking, if women decide I need some birth control pills, that means that they're deciding they're going to be sexually active, generally. And to say, let's honor that they have made a decision about that and give them the tools that they need at that point in time, as opposed to putting them in a system which is stacked against us anyway.
That's right.
To wait, right? Because that's another challenge that the United States has around sexuality, right? Is that women are not supposed to be sexual. We're not supposed to be able to make a decision that we want to be sexual and exercise that decision, because we're supposed to have men controlling our lives. That's supposed to be driven by men, whatever. So that's where Black Women for Wellness, or Jan Robinson Flint in particular, decided to look into this concept of, are pills safe? And should they be given to women like on demand, really? And then how do we connect women to healthcare systems that work for them, as opposed to victimize them?
Right on. Thank you, Jan, for that valuable history. I want to move us to the present day and future. Yeah, and I was going to put it right to you, Dr. Villanueva.
I was just going to add, now, I mean, I'm like mesmerized. I'm fangirling right now on Jan. But, I think the point that's made is that we've sexualized just normal female health and normal health for women being able to control when we have children, getting contraceptive options. That's just part of our normal healthcare. That's not, and we've sexualized that. And so now there's a stigma attached to it and makes it difficult, especially for women of color, to be able to just access normal medication. So I think that's such an important point. And that's, that happens to women every day about many things that we do, even feeding our own children in public. So, so I think that point can't be, we can't underscore that point enough, how this is just routine medical care for women. That, this is not endorsing sex, endorsing certain sexual practices. This is just providing women with their health care.
Dr. Villanueva, to toss it to you, I'm curious, as a provider of color, right? Like if there's more perspective to the ways medical care has been rationed or, gatekeepered, and what some of your activism work has been around to undo the historic and systemic inequities that are cultivated by our medical system, but also if you could bring us to the future today about how is birth control, how has it been helping people get birth control during COVID or during these modern times? What is it like now?
Yeah, I would say I'm just really, before I go into that, I'm just really grateful to have had this opportunity to be part of this conversation. I think, the NMA representing Black OBGYNs, Black women's healthcare practitioners, Black family practitioners, really in large part taking care of our community. We should, I'm, embarrassed that we have not been at this table before in this conversation. So I think it's really important to understand that we support the ability for women to have birth control over the counter. It's so important to have that access. And so, NMA will definitely be part of the conversation going forward. So I'm really excited about that. But of course, we know that in our healthcare system, communities of color have always been underserved, have always been marginalized, have always experienced racism and bias, and all of these things have led to poor outcomes for us, for poor access to routine healthcare, to the fact that we don't want to go to the doctor because of these experiences that we've had. And these aren't long ago experiences. These are experiences that we have today. These aren't just history of forced sterilization or history of being experimented on. These are women going to the doctor today. I have many women coming into my office just talking about not feeling heard by a practitioner, not having their concerns validated, that they've brought these issues up for many years and no one has ever thought to run a test or do blood work or just really explain to them what they're experiencing. So I think that part of our medical system needs significant work. And I think it's work at the level of training in medical school and how we, obviously medical school is a training ground because people have to learn how to be practitioners and providers, but it needs to be a respectful training. And I think that has been lacking in our healthcare system. There's a lot of work being done in all different areas to improve this. And even the fact that we can talk about racism as an issue leading to disparate outcomes is a step forward. I think when I was in medical school, it was a person's race that was the issue. But we know that's not the case. Black folks aren't defective. It's really, it's racism, it's bias, it's implicit in our system. It's what our system was founded on, right? It was separate but equal, but it wasn't equal. It was substandard, right? That's why NMA was founded. 1895, we were founded because we could not be part of the American Medical Association. We couldn't get credentialed in hospitals. And so, like Black folks do, we made our own, and we made our own organization, credentialed our own and educated our own physicians so we could take care of our community because we saw what was happening at the time. So I think, just as Jan was saying, we have to remember what the history is because this, we're dealing with many years of social, structural, economic policies, practices that have worked against people of color being able to get access and being able to get quality care. So, those are just, boy, that conversation, I'm like, my papers are flying. That conversation is just a lot. I'm really grateful for the fact that in a way, I know it sounds, grateful may not be the word, but I think COVID has been able to shine a light on these inequities that many people did not understand, right? And so, you know, it did serve more than, it's been more than just a negative impact in our community, because it definitely has been that, but it has really opened up this conversation, as well as all of the other social issues that have happened around the murder of George Floyd and the murder of other Black souls in our community, that we've been able to have more open discussions about what disparities exist in our healthcare system. And so contraceptive care has always been an issue for women in our community, whether it be cost or access, or even the opportunity that practitioners don't have a bias against what they think you should get, as opposed to what you actually want to get. But in COVID, you know, doctors were actually forced, and the federal agencies were forced to actually cover us being able to have televisits with patients, and that being a way that you could provide healthcare. I think it's been fortunate and great and expanded it in some ways, but then we also know in our community that not everyone has a smartphone, not everyone has access to a computer, not everyone has broadband that can support these things. So I think whereas it has opened up some doors, and for me, it was a way I could keep connected with many of my patients, and many patients really appreciated the ability to have telehealth. And it was interesting because I had a lot of patients where I felt more connected to them on a telehealth visit. I think in like their own environment, they felt less inhibited. I felt like people who were more reserved when we were in person were not over the video. I know that doesn't always work in that direction, but I definitely, felt that way. I've actually felt patients have kind of accessed me more and wanting to do televisits, especially to talk about contraceptives, whether they wanted to change things that were happening to them, because it's all often difficult for, as we're talking about access, to just come in for a visit, to take off of work, especially in our community. And so that being able to jump on for 15 minutes, and it makes a difference. It really does make a difference. So I definitely have really appreciated more the opportunity, and definitely my patients have as well. I can't, really every day someone saying, thank you so much for having this ability for me to talk to you, whether it was about contraceptive or whatever, but just the ability to have this kind of additional access or touch point with their provider, and kind of creating more of a relationship, I think has been just maybe the only positive of COVID. Yeah.
It's neat to hear you describe the kind of barrier to access of care being slightly reduced over COVID because of telehealth, and particularly in the context then of contraception. What do you think, and this could be, to any three of you, for Black women in particular, and thinking about birth control, if it's easier to do a 15-minute televisit and you're more honest and kind of authentic and more open, like, what could even easier access do? How could that transform people's lives? But Dr. Villanueva, to continue to your thought, what do you think?
Oh no, I think it would be crucial to being able to for certain women to be able to have contraception and just have the autonomy to decide whether they can protect themselves against being pregnant if they so choose at that time. And so I just think it's difficult to really think about that you all have been in this fight for so long, right? I mean, just hearing and why. It's just, emergency contraception is over the counter already. It's the same it's the same form of contraception. So if that has been used over the counter, those barriers, it's illogical. And so I'm joining, I'm in it.
Right.
You're not going to be able to get rid of me now. So
Yeah.
just FYI. Just FYI.
We're glad of that. Jan, you want to jump in onto this?
Sure, I can reflect on that for a moment. And just, I do think that the telehealth that has come into being caused by the pandemic is a good thing, right? That many times people are able to be in this room, right? In this Zoom room, and be, honest and forthcoming to say, this is what's going on, and feel heard because it's just me and you in this room, as opposed to the waiting room, the frontline staff, and all of that they have to go through to get to you. And you might only have like 7 minutes, right? At that point in time. So I do think this telemedicine and being able to touch people in this way is a good thing, right? But I also know it has drawbacks, right? So it has drawbacks for all the reasons that Dr. Villanueva mentioned, right? It's like everybody doesn't have access, broadband, the smartphone, a computer to make it happen. And everybody's not in a safe space, right? Some people are very aware of who's listening in the next room. Some people don't want their children up in their business, right? So it has that thin line that we have to be very conscious of. And I'm very conscious of it because when this hit in March of 2020, we had to send our whole staff home. And when we sent our whole staff home to work from home, everyone was not equipped to work from home, right? And it wasn't something that I had thought a whole lot about until I started saying, wait a minute, this whole team can't work from home. What's going on here? Who has access, or who had, broadband access, but now they have 5 people trying to use, internet at the same time, and what difference does that make? So telemedicine is good, but we can be so much better in how we, make sure that this happens. It is so critical that Black women are listened to, right? And because us being listened to will save our lives, right? When we have relationships with providers, and that's one of the things that Black Women for Wellness absolutely promotes, that you create relationships with providers, and a relationship where they hear you, they hear your concern or they hear your pain, and then they address it in a way that satisfies it, that shows not only are they listening, but taking into consideration all the things or considerations that you have to take into consideration.
Yeah, it was interesting. We got a couple of questions from participants before the webinar, and some of the questions were really on this topic that you're talking about, and how do we, and I assume that some of the people asking the questions are not Black identified or women of color identified themselves. Like, how do we have the cultural humility to treat Black women patients, right? Knowing that there's often this history of mistrust for good reason and systemic inequities. And so just to summarize, I'm hearing some, nuggets of really good wisdom from you all. One is, spend your capital, political capital, your white privilege to work on campaigns that improve access, right, to all the different things. So, whether it's putting pills over the counter, but also broadband and, economic equity and housing equity, environmental justice, doing that. Second, Dr. Villanueva, you mentioned it in your bio about how NMA really works around pipeline issues. And because you weren't allowed to be doctors, first of all, women weren't allowed to be doctors, right? It was all white men were allowed to be OBGYNs, right? And then it was like slowly women, and then now people of color and women of color are slowly catching up. So ideally for patients, it sounds like giving them choices and options to see someone who looks like them or comes from their culture and understands them. And if you can't, then to practice all of the kind of great cultural humility connections work that you can do, and really listen is what I heard you say last, Jan, right? Like as the most important step. I want to address maybe some of the questions that we've heard from potentially those who are doctors or part of the medical profession. And so, Dr. Villanueva, we've heard people ask questions about whether a potential OTC birth control pill might impact how providers engage with patients, especially for screenings. How do you think this affects your ability as a provider to screen for things like smoking or STIs and cervical cancer? And it's been kind of used as an excuse to be against this idea of, oh, if they can get their birth control, if women can get their birth control at the gas station, then they won't come to their doctors for all these screenings. Tell me what you think about that.
I don't believe that at all. I think women are very engaged in what happens to their bodies. And so women want to come to the doctor. I mean, women want to understand what's going on. Women want to talk through questions that they have. So I don't believe that it will affect their ability at all to get screenings. I don't believe that at all. I think there's even been research done that women, if given the option, would still come to their primary provider to get health care. So, I think we have to always think back on the history of how medicine is just a patriarchy and how we think we know what's best for patients. We have medical knowledge, yes, right? We're not going to discount that. And we have expertise in that knowledge, but we also have to respect the expertise that our patients come in with as well. And I think that's where the cultural humility happens, whether you're a person of color or provider of color or not, right? I think that definitely the understanding of people's lived experiences and kind of understanding, and I think that not everybody comes from where you come from, and you have to understand that they may not live, as Jan was saying, in a safe space. They might not be able to just walk outside and exercise when you tell them to do that as part of their health, all of those things. So I think really just being at the core of what is a good provider is listening to your patient, really listening, not just like being able to fill in a couple of things on your checklist as far as their visit, but really listening to what they're saying, listening to what they're not saying, what their body language, everything, and just really understanding that not everyone comes, even in communities of color, we're not a monolith. You have to really take the time to listen and understand where someone is coming from. And I think that's the most important part of being a good provider, but especially when you're dealing with someone who may look different than you are, and you think maybe they have an automatic distrust of me as a provider because I don't look like them, or they may not think I understand where they're coming from. So, we don't have that much time in a session with a patient to actually build that trust, especially with a new patient. And so, even our body language, how quickly we, interrupt somebody, how much time we give them to tell their own story is, all those things are important in kind of creating that trust and that relationship, immediately. Because if you don't, that may be that missed opportunity to help somebody, with whatever medical issues they're having, or to educate someone who wanted birth control. And now they really aren't listening to what you're saying at all, and don't trust what you're saying at all. So I think that, medical education is the cornerstone of that. And we need to do a lot of work on that end as well.
Doc, I think I just kind of screwed myself up because everyone's going to want you to be their doctor, and now I'm never going to be able to have an appointment, and I messed up. I shouldn't have asked you to do this.
He's funny.
But I think that's
I want
exactly
to
right.
weigh in for a second here.
Yeah, please, Jen.
I think you are absolutely correct. That listening is so key to being able to be an effective healthcare provider. But I want to put in a good word for midwives, right?
Yeah.
Because there was a point when midwives were the ones providing the essential reproductive health care and whole woman care, right, to women. And midwives did a great job. And they still do a great job. But now we got to get folks in the pipeline to be midwives, right? Because the one thing that the AMA did, not to be confused with the National Medical Association, they drove midwives out of business, basically, right? Because midwives came to you, they came to your home, they came to see and work with you in your space to create a healthy space for you. And then they look at the total family and at you as a person, not just your body parts, to help you make good decisions about where you wanted to go with your health and how you needed to go there with your health. So I just had to put that word in all the time for midwives, because they are such an essential medical profession that we really need to lift up a lot more and realize the history of what has happened with midwives in this country, right?
Yeah.
And it made me think of two things also. So I have been on doing a couple of research projects with Cuba. And the first time I went to Cuba, is like they have doctors for every 600 people. That's amazing, right? But what's also amazing is the doctor has to live in the community that they serve, right? So we could be walking down the street and someone would yell out the window, "Doctor, come check my blood pressure. Something's not going on," right? Or something's wrong. And the doctor would say, "Okay, I'll be there in a few," and go get their blood pressure checking equipment and come back and check that person's blood pressure. That was the relationship that they were developing. And I'm like, why can't we aspire to that type of relationship with our healthcare providers? That they are accessible in our community. They know our community, our environment has so much impact on our health and well-being.
Yeah.
Right. So, and that creates access, that creates knowledge. They know that I live in California, and there was a stench in the air because there was some toxics dumped in the river. They know if something happens like that because they're right there too, and that will have an impact. People will have headaches, or they'll have irritated eyes, or they'll, something is going on. So that's how far we have gotten from medicine, that we really need to take that concept of Sankofa in terms of looking back to move forward, right? Yeah. We should absolutely be improving our technology. We should be improving our meds. We should be improving birth control pills so that they are safe. But we should also be looking back to how do people access health, right? And then the last thing I wanted to mention, Black Women for Wellness passed a bill, the Dignity in Pregnancy and Childbirth, which really asks perinatal providers. So that was all the frontline staff that deals with expectant people to be trained with implicit bias, right? We call it our anti-racism training bill, right? And those types of policies need to be put in because those implicit biases are killing us. That racism, that we have not made that decision to really just deconstruct the system and start something new, is killing us. Mm-hmm. So we are trying to put some Band-Aids on until we can do that. And implicit bias in that training in that particular law is one of the things that we have passed in California to make that happen. Mm-hmm. How does that impact? Do Black women have access to birth control pills, right? It makes, or it asks rather, that those who are prescribing birth control pills, that those who are setting up systems of healthcare and access, whether it's public health or medical services, check their own bias, whether it's gender or race, to say, how do we create accessibility for all people?
Right on. Congratulations. That's incredible. Terrific work on that, and so necessary. I love the way both of you are describing like the historical context of patriarchy and racism that get enshrined in our systems that have taken ourselves away from our own internal wisdom about our own bodies, right? Like that's what patriarchy did. They said, women, you don't know your bodies. I'm a white guy doctor like J. Marion Sims, and I know your body more than you. And it's so hard and painful. And I think this campaign is so valuable in helping undo some of that internalized sexism and racism. So I do want us to get Victoria in because, you know, today is a slightly different day, and today is a better day than it was in 1905 or 1895 before then. Where are we in the process of getting a pill over the counter? And how have we as part of the campaign been part of that?
Thank you so much, Miriam. And I just want to thank the two other panelists. I've been just soaking in everything that you've been saying, and it resonates really deeply with me. And just to kind of provide a little bit of context around Free the Pill and the coalition that we're engaging in this work, Jan mentioned that this coalition has been working for over 15 years on this issue. It started in 2004, and it's grown to be over 100 plus organizations and individual members that are really committed to this issue. And we're at a really exciting moment in the Free the Pill campaign, because we do anticipate that a pharmaceutical company will submit an application to the FDA in 2022. So although it's taken a very long time, this is really the moment for our coalition and our campaign. And for those who don't know, the kind of process for a birth control pill to go over the counter is through the FDA, the Food and Drug Administration. So the process would be a pharmaceutical company would submit an application through that agency, and then that agency would make a decision. And we're hoping that this will be a groundbreaking expansion for access. But the campaign really focuses on laying the groundwork to ensure that policymakers allow the FDA to conduct a review of the application that doesn't have any political interference. And we're really working to ensure that once a birth control pill is over the counter, that it's covered by insurance, that it's priced affordably and accessible to people of all ages. So that's really something that's key to our campaign. And we're actively engaging, given that this is going to be a really big year with members of our coalition. We have a strong partnership with our colleagues at Advocates for Youth, who have a Free the Pill Youth Council that is engaging in organizing young people to really talk about this issue, to advocate for themselves around expanding access to birth control through an over-the-counter option, what that would mean for people who are younger, who face additional barriers to access because they're young people. We're also wanting to engage with provider groups. We have a lot of provider associations signed on to our statement of purpose. There's organizations like the American College of Obstetricians and Gynecologists that have supported an over-the-counter birth control pill. We're hoping that more provider groups join that cause, and so we're engaging with them. And we're also thinking about other groups to engage, moms groups, parents groups, other groups that have an influence and an opinion on this. We want more support from those groups, and are working on that as well. So that's where our coalition is at. As Jan mentioned, one of the reasons why Black Women for Wellness and other groups are involved in this work is because our coalition is truly grounded in reproductive justice issues. We want to ensure that this is not a regular switch to an over-the-counter product, that it's truly expanding access in an equitable way to ensure that people with the most barriers, we're talking about Black women, Black people, people in the LGBTQ plus community, Indigenous folks, immigrants, young people, that those folks people working to make ends meet, that those folks have access to this once it goes over the counter. So that's truly what our campaign and our coalition is grounded in.
Yeah, I love this campaign is not just about what we're trying to do, but how we're trying to do it is super important, right? Like it easily could have just been, you know, a bunch of white researchers or white advocates saying we should do this. It would be a good idea, you know, but the leadership of this coalition has been RJ and youth led for, you know, the majority of the life of this campaign. And so centering the needs, the desires and the leadership and the strategies of reproductive justice are really, really core. Speaking of leadership and activism and advocacy, first of all, open invitation to anyone who's attending, if you haven't signed on to the statement of purpose, to join us. Rachel just signed on. I just saw Nima's name, so yay! I don't know what the official number is, but it's +1 at least more. But in terms of the advocacy work that we need to do, what do you think are some of the national policy changes that we can be pushing for? Like, how can politicians support us? And we also have some political leaders and staffers from congressional offices on this webinar with us. What could they do to help us, and how can we push them?
Sure. So I talked a little bit about the FDA process. That's certainly one avenue that we're exploring, but there's also the issue of affordability and insurance coverage, and that's, I think, truly a really big place for members of Congress, policymakers to play a key role. Under the Affordable Care Act, insurance plans cover contraceptives, but the methods have to be covered, have to be prescribed. So the condition for coverage is a prescription. And this practice really creates barriers to OTC access and will create barriers for an over-the-counter birth control. So comprehensive insurance coverage is really key to this issue, and it's one of the really big objectives of the Free the Pill campaign. So this is one example of a way that policy could change, is that we could change that prescription requirement under the ACA. That would be a huge win. It would expand access and ensure that and help ensure that a future OTC birth control pill, once it's over the counter, is covered by insurance. I also want to acknowledge that beyond like the federal opportunities, there's also a lot of great state work that's happening. We partner with state advocates who are moving in terms of working to build policies for OTC access in their states. So that's another great avenue to push for policy change, and know that we have a lot of state advocates that can speak much more specifically to the work that's going on in their state. But that's something that I'd call out as two kind of ways to change policies to expand access to coverage.
Right on. And it, you know, also just a plug, I think some people are thinking about really innovative models of expanding access and affordability as well. So trying to work at, you know, for instance, like how is it that we get free COVID tests nowadays, right? Like with not a lot of overhead and, you know, difficulty for the end user. Ideally, that would be the case for us to be able to take care of our health if we want it. So if any of the attendees are grappling with these questions and want to work with us, we invite you to join us in designing some of this too. Tell me, Victoria, about you know, there's been a long body of research, right? Like if you just don't want to take Jan's word on it and then Dr. Villanueva's word on it, which obviously you just should because they're brilliant and amazing. But if you don't, and you want to follow the science, what's the most kind of important and critical research pieces that you want to lift up about how to move OTC birth control pills over the counter?
Sure. So as we've mentioned this before, this has been a 15+ year journey. So we've been building, this coalition has been building the research and the evidence and the data for almost 2 decades now. So there's a lot of research to point to. There's a host of resources on our website, the OC's OTC Working Group website, which we'll put in the chat. But just want to emphasize that birth control pills are one of the best studied medicines on the market today. They have decades of research in terms of the experience. There's lots of research that's come out of other countries as well. There's been research done on the US-Mexico border. There's been research done in Mexico that is a country that has OTC access. So kind of comparing the satisfaction that that folks who access birth control in Mexico to the farms within the pharmacies to clinic access in the US. There's some really great research on that shows that compares those two groups and provides some data on that. There's also lots of information and research that's been done on access for people of all ages, how people are interested in this, and what benefits it would really give to different groups that we've looked into. So encourage folks to look on the OC's OTC website to get more information about those research pieces. But I think it's really important that the research gets translated into policy change. We have this body of research. We know that birth control pills are safe and effective for over-the-counter use, and it's really time to expand access, particularly for those who face the most barriers.
Right on. So again, before we move into Q&A, which I think we will do shortly, so if folks want to start writing and composing questions into the Q&A box, we invite you to. Victoria, remind folks of the process. It's not that like all birth control pills will go over the counter at once, right? So remind us of that. And also, how much do birth control pills cost? And how much do women think or people who are pregnant capable, or people who just want birth control, think that they can pay? What do we know about the affordability pieces?
Sure. So I mentioned before that in order for a birth control pill to go over the counter, it has to go through the FDA process. That is focused on one formulation, and it's one product. It's not all birth control pills going over the counter at once. The FDA reviews the data and the science for that particular birth control pill and makes a decision on that. So it's a gradual process that would be one product at a time. And then to address your other question in terms of price, the price of birth control pills now varies. It can be anything from free if you have it covered by your insurance, or I think the range is between $0 and $50 a month. And $50 a month can be a lot of money for some people. So it's important to keep that in mind. In terms of an over-the-counter birth control pill, the price would likely be determined by several different factors. Some of it has to do with what the pharmaceutical company sets as their price, and then there are other kind of things that go into the the final retail price. But when it comes to price, I think it's also important to think about what the out-of-pocket expense is for consumers, and would that increase for over-the-counter pill if it's not covered by insurance? Because many people are covered by insurance, but it's also to think about the uninsured population and what the impacts will be for them. So I think that it's not only about insurance coverage, but it's about affordability in terms of the price as well. And the Free the Pill campaign is really working to ensure that we have both, so that people who have insurance can get it for free, and then people who don't have insurance can get it for as low of a price as possible.
Great. Thank you, Victoria. So I invite folks to chat in their Q&A and start to do that. And want to invite Jan and Dr. Villanueva, if you have any comments you want to add on to what Victoria is saying, or anything you want to add on to some comments before. I know this is the moment in a panel where I'm like, oh, I wish I had talked about this. So
Right.
I'm giving you that chance. What's that thing you had wished you had said earlier?
Well,
I think I have one thing, and I'll let you go. Just in terms of, we're having this conversation about insurance and people who have insurance and don't have insurance. And one of the things that we may have noticed during this pandemic is how important it is for everyone to have access to medical services.
Yeah.
So as part of a policy, I am hoping that we will continue to put single payer or universal health care on the agenda, because it is critical what we have to decouple this issue of insurance and employment also, right? That everybody gets access, everybody has, quote, health insurance. So I think that's the one thing that we have to talk about, because many times if we're talking about young people, right, their insurance is totally reliant upon their parents, right? And the Affordable Care Act gave young people up to 26 that ability to still be under their parents, but it still sent the bills to their parents' home, right?
Mhm.
So how do we create just universal access or single payer as a policy issue? Because we really need to look at that. So that was the one little burning thing around policy. Like, okay, it's great that we do this piecemeal stuff, but we need to look at that big picture also.
Mhm.
Okay, I'm gonna rest there and go ahead and let Dr. Blue say what she was going to say.
Yeah, thanks. Just a couple things. I'm going to go way back to when you were talking about midwives. Midwives are the reason I'm an OBGYN, actually, because when I was in medical school, there was a huge midwifery program at Yale, and they were the ones that I did all of my deliveries with. I delivered so many babies as a medical student. I never wanted to be an OBGYN. I wanted to be a pediatrician. And then I did this rotation and that was my exposure. So I am, we definitely in the United States need better care models as far as just women's health care, using midwives, using doulas. So I think expansion of policy to support and fund those providers of women's health care is critical. And we know that other countries do a much better job of that than the United States. And other countries use midwives and use doulas primarily, right? And so I think we have to have a better balance of that. And it's not like one is better than the other. We're all part of a healthcare team for women. And I think we really need to do a better job of that and to fund that. I think there needs to be funding behind that. Mm-hmm. The other things I would say as far as policy, I'm going to go from the physician end, is just workforce diversity, right? We know that providers of color take care, and patients do better when they're taken care of by providers of color. I think Jan alluded to that earlier, right? There's better compliance with treatment. There's better overall experience from the patient side. There's just better health outcomes, lower mortality rates for neonates. That's been well documented. So I think there's just so many reasons that we need more than 5% of the workforce being Black, of the physician workforce. 2.5% are Black women. I'm always shocked about that too, because I think I know so many, right? I know so many. And then in NMA, when I go to my medical meeting, that's all I see. But that's probably all of us. No, but it's just, so I think really putting effort behind policy that will expand our workforce and all healthcare professionals of color, not just physicians, but PAs and midwives and nurses, all of those who are taking care of our community. We need to expand that workforce, and there needs to be federal dollars behind that. I mean, that's just the way it is. And then the other thing I just wanted to talk a little bit about is just making sure that people of color have a health home. And I think that Jan mentioned that how critical it was for people to have healthcare during the pandemic, but people also have to have a provider and a practitioner that they trust and they can go to when they need care. And I think that is so important that we can't underscore, like even, having access to over-the-counter meds, over-the-counter birth control is important, but also being able to have a provider that they can go to if there's an issue is also really, really important piece of total care. So those are just some things I wanted to touch on.
Well, before there's an issue, to prevent that.
Mm-hmm. right? Increasing access. Great. 2.5%. That's like the experience of being a lesbian in this world. So, you know, I feel like I know all of us too, and there's so many, but really. Just, there have been some questions in the chat and some questions that came in before about how do you respond to people who aren't interested in taking hormonal contraception or have concerns about side effects or misuse?
Yeah, I get that every day. So I really just listen to what I just, some people will say, well, these are your options, or based on what you're telling me you need, I think this would be good for you, like an IUD, for example. And they'll be like, no, I'm not doing that. I'm just not doing that. And it's just a matter of listening. Like, why have you ever tried it? Did you have a bad experience with it? And just understanding what their concerns are and really going through it's really like dispelling all the misinformation about anything, about all the COVID vaccine misinformation, right? People hear things, or they have one friend that has a bad experience and then they think that's their experience. And I'm always like, well, just because your girlfriend can't wear that you can't wear that pair of jeans, is your girlfriend not going to wear that same brand of jeans? Or are you not going to, it boils down to those things. Everyone is such an individual. If I can at least kind of like try to talk through what their concerns are, because there's usually a reason. There's usually like they have a specific reason why they don't want to try it. And a lot of times it's just talking through and really getting them to understand what their issue is. And yeah, so I think that's the important thing. Again, going just back to really listening to what the patient is saying to you. Yeah.
I think that's the key word, listening to what people are saying, right? To listening to what their lifestyle is, what their environment is, what their circumstances are, and then helping them make an informed decision about what's best for them. And to do that, one needs to listen and ask questions.
Mm-hmm.
I think that one other thing is just in the OTC context, we're simply expanding choice. If someone doesn't want to take a birth control pill or doesn't want to access it over the counter, that's fine. If they don't want to be on hormonal birth control, that's also fine. But at Free the Pill, we're really, the thing that we're talking about is getting a birth control pill on the shelf so that it's just an option for people. And if they want to go back and talk to their provider, that isn't always an option for people to do if they'd like more information or want to talk about any kind of side effects or questions that they have. And then just another note is that every medication has side effects. Every medication has things that you have to consider. You have to weigh your options, what your tolerance to certain symptoms are. That is an individual's choice, and having a birth control pill over the counter wouldn't change that. It would only expand the options that are available for people.
Mm-hmm.
And then it's just important to also remember that these pills are not just used for contraception, right? They're used for hormonal regulation and other medical issues. And so the increased access and ability to access them without needing an appointment, it just means that people can continue their medical care and don't have like interrupted points of care. Some women use it for like heavy bleeding where they can't go to work, or they're bleeding through their pants. Or, it really is used for many things. And so the increased access is important to women for a lot of reasons, not just contraception.
Right on. Yeah. So one of the other concerns or kind of pieces of opposition that we anticipate or people have are around young people's access to contraception. And I think this goes back to what you were saying around patriarchy, right? Like, and racism, add ageism into this. What do you think about young people? What do you think about young people and access to over-the-counter birth controls? And what do we know about young people and birth control potentially going over the counter?
I'm happy to.
Young people need access to.
Oh, go ahead, Jan.
Excuse me. I was going to say young people need access to birth control and family planning. What we know is that young people actually, the vast majority have great relationship with their parents and or guardians, and talk to them and they are helpful in them making these decisions, right? So is not like, we anticipate young people wilding out and, buying birth control pills, like they have that kind of money. So we have to remember that young people are able and should be able to make decisions about their body, that young people need the information and resources to make decisions about their body, that young people are more than likely in conversation with their parents about their health and well-being, and that young people also deserve to be in conversation with healthcare providers about their health and well-being. So that we as a culture and a society really need to get over our need to manipulate and control other people, right? Because I think that's where that comes from, right? And that's what we really need to get over, that need to manipulate and control people.
Victoria, you want to add on?
Yeah. Sure. Happy to add to that. I think that one thing to note is that the American College for Gynecologists and Obstetricians supports a birth control pill over the counter for people of all ages. So I think that's one thing to note, and that there's lots of support from young people, support and interest from young people in this. As I mentioned before, we partner with Advocates for Youth, who's organizing young people around this. We just did a really great webinar in January that lifted up young people's voices on this, and happy to share that as a resource. And there have been some surveys and polls of young people, teenagers that have been done that have found that the vast majority support OTC access. A poll in Teen Vogue said that 76% of young people ages 18 to 34 believe birth control pill should be freely available without a prescription. Our kind of colleagues at IBIS have done research on this, and we're happy to share links around that as well in terms of its safety and efficacy for young people. But there's a lot of support, there's a lot of interest, and I think reiterating Jan's point about not manipulating or controlling other people based on what our beliefs are, it's really important that young people have autonomy and control over their bodies. And so I think supporting young people's access to a future over-the-counter option is really important.
We know also that 69% of parents that we polled also support bringing birth control pills over the counter.
Yeah, and I think that one thing is that we can't underestimate, just because they're young, really they're very savvy, they do their research, and they come to you with very pointed, like very good questions about how potentially being on this medication will affect them. So I have no reservations about the access to birth control for youth. I think it's critical. It's really critical to, more importantly, to prevent unintended pregnancies in that population. I think, again, try, as we've said, just to separate personal beliefs as, from what's needed for healthcare and people's ability to have autonomy over their own bodies. I think we struggle with that in everything in our country, but always for women. I think it's very, it's very interesting. There's autonomy, for people not to wear a mask, that's their right, but it's not autonomy for women to be able to do what they want with their own bodies. I mean, you can't make that up. I mean, so I think we have to continue to just advocate for ourselves and advocate for the fact that, these are our basic health rights. This isn't a sexual right. This is our right to control our own bodies and to remain safe and healthy.
Yeah. Yeah, the number of signs I've seen, my body, my choice, without the kind of context is so wild. Totally. All right, some practical questions are coming through the Q&A. So some quick and easier ones. Would we be able to recommend some books about the history of midwives and understanding the difference between midwives and doulas? Jan, any quick hits on that?
There's a book, Listen to Me Good, on the history of midwives. There are also a couple of midwives associations. I'll have to think about their names and drop them in the chat or send those to you later. The difference, but there's a significant difference between a doula and a midwife. A midwife is a healthcare provider. A midwife can give medical services and catch your baby. A doula is a cheerleader, a coach, the advocate for you to help you interface with the healthcare system. So that's the difference. So, and it's significant just in terms of, a doula can come to your house and you can have a baby, but you have to have that midwife with you, or you have to have a doctor or a nurse practitioner. So a doula can go to the hospital, but then that doula will have to interact with the rest of the healthcare system also. And there's truly a hierarchy in the hospital when you go. So significant difference. I'm all about midwives, but I also support doulas.
I'm not gonna take that personally, Jan. I'm not gonna take it personally. No, I'm just kidding. I'm just kidding.
Dr. Rachel definitely doesn't take it personal because she's not only my doctor, she's my partner's doctor. My partner at one point said, we're going to go with a midwife for our babies. And doctor was like, okay, you do what you get what you need, right? Like, so I know for a fact you don't take it personally.
Responding to the question, it didn't ask me about OBGYNs. They asked me the difference between midwives and
Are you for OBGYNs, Jan?
I am for OBGYNs.
Okay,
absolutely.
Just making sure. No, I think.
But I also think it's very critical that people know the difference between a midwife and a doula, because doulas have been lifted up a lot. And I think midwives need that same lift. And midwives need also to be in that pipeline of healthcare services, right? Or of education for healthcare services, as much as I think that OBGYNs do, because do I know the whole 2.5% also? Because I feel like I know so many like OBGYNs. Like we have to figure out how to get out of our echo chamber.
A Black OBGYNs, I feel like I know so many. But when you look at the numbers, we're just like a little chocolate drop in the water.
Yeah, and that's a wonderful chocolate drop. And we have to figure out how to spread that around.
But I think, I personally really encourage patients to use doulas, right? And there are especially some patients that I will encourage more than others, because it also depends on like relationship with the partner, right? And what the partner can give you, and maybe needs. Sometimes you see a partner and they're just afraid to even stand in the room. And then you're like, you might really benefit.
You might be a doula.
You might be a doula for labor, right? So I think as we're talking, it's such a critical, like the whole team of people is so important in women's healthcare.
So I'm going to say a postpartum doula is absolutely critical too. That first year after pregnancy is so important. And when a partner and a pregnant person go home with the baby, sometimes it's like, now what? And that's when it's like so important that doulas can come in and say, okay, let's get this party started, because it has, right? This is how we, do sleeping and lactation support, those type of things. So
I love it. We've gotten some good resources also from the experts on the attendees panel. So Jess, if you can go ahead and share those brilliant resources as well, that's wonderful. Okay, will an OTC birth control pill actually work and look? We've gotten kind of a coarse set of questions there. And how will the business model look? Mind you, the attendees are asking us as advocates and providers and nonprofit people. So none of us are pharmaceuticals. None of us are paid by pharmaceuticals to do this. So these may be questions that are better asked to the pharmaceutical company. But what do we think it will look like, Victoria?
We can imagine, and we can definitely hope. And we're, at Free the Pill, we're trying to think about how do we create a system in where someone can walk into a pharmacy or a store, pick up a product off of the shelf, pick a birth control pill up off of the shelf, wipe it, have no cost, and then leave. That is the ideal model. That is what we're working for. That is what we're trying to explore. The mechanisms of making that happen are things that we'll need to figure out, but I think that is the gold standard that we'd like to implement in terms of getting this truly over the counter. We don't want it behind a glass or behind the pharmacy counter. We want it on the shelf so people can truly have access to it. Another thing is important around ensuring that it's available and accessible to people of all ages. It would be a huge barrier if at the counter someone was asking for an ID. That would be a barrier not only for young people, but for people who don't have IDs. Think about immigrants, other communities that may not have IDs. So that's something that would be a challenge or a barrier that is another reason why we're pushing to make sure that it's accessible to people of all ages. But that is our kind of thinking in terms of what it would look like for it to be over the counter. The business model, I'm not sure if I can quite comment on that. That's probably more a question for a pharmaceutical or someone on that side of it. But Jan, Rachel, any ideas from you in terms of what it could look like?
I mean, is it safe to say we could imagine anywhere we get an over-the-counter drug, like I need a Claritin, I need a Benadryl, I need an aspirin, like all the ways I can get that. So that means I could go to the pharmacy and pick it up, write it down in the block. But if I live in a rural area, which is another question we got, how do we imagine this in rural areas? Maybe it's easier that it comes in my online CVS box, which also sends me my toilet paper, or I mentioned the word gas station before. It's kind of like a toss aside, but like you can get an aspirin at a gas station. You can, right? Like also you can get condoms at gas stations, right? So I know our friends in the EC campaign, emergency contraception campaign, many folks, particularly young folks, are working for vending machines on college campuses, right? Wouldn't it be great? We could imagine it there too. Ideally, of course, covered and cheap and, or at no cost. But sky's the limit, and I invite people to offer their imaginings in the Q&A now about how would you like to see it work? What would be the simplest for you to meet you or your community's needs and goals?
Yeah, and I think what Victoria said about even barriers for being behind the glass, because we even saw that with emergency contraception, that even though it didn't require a prescription, but the pharmacist had to physically give it to you, it was behind the counter. That's also very much a barrier. I remember even I had a friend who personally needed emergency contraception at the time that you actually had to write a prescription for it. And even though there was a prescription, the pharmacist refused to dispense the emergency contraception to her. So we can only imagine, right? That was a personal decision by that pharmacist. There was a prescription to not dispense that medication. Mm-hmm. So, all of those little, that was a prescription, but now even just the fact that the pharmacist may decide that they don't feel like this is right. Mm-hmm. And they won't give it to that person, or because of age. So all those barriers, we need to make sure that it is as simple as like picking up, I was going to say Benadryl, but is that behind the counter now? No.
That's over the counter.
Oh, no, yeah. But there's some things that are behind.
Yeah, you're
Sudafed,
right.
that's right. Sudafed.
Yeah, yeah. But this, we just got another question, not just for age or any
Before
reason,
we
but
move
of
away
course,
from that,
gender. Oh yeah, go ahead.
one of the challenges that sometimes happens in urban settings is that things get locked up also, right? Even condoms get locked up, right? So because I have heard that it's because, condoms walk out the store without being paid for. And I'm like, good. Let them walk out the store without being paid for. I don't care, as long as, but, and I think that's the other consideration when we talk about where do we have over the counter anything in terms of the medical or healthcare needs that folks have, right? And how do we create those wellness centers where folks go to get it, and we don't have to worry about them being behind. We don't have to worry about them being gatekept by a pharmacist, or we don't have to worry about the cost, right? Or the guilt or shame or other, feelings that come along when you need to go and get your birth control pill or your condoms or your plan B, so maybe that's, we need to start imagining wellness centers that are not, quote, doctors' offices, but where people go, and maybe, you need condoms, or maybe you just need some bath salts or lavender or whatever. But we remove the guilt, the shame, the humiliation, the trials and tribulations, and the people who are judgy. That's right. Whether it's the pharmacist who's being judgy or the cashier who's shouting your business, price check across the store.
Yeah. Right on. And we're going to work hard even after the first, second, third, maybe fifth, maybe 50th pill goes over the counter. One can dream, because right now we know there are 2 products moving its way. So there'll be some time to catch up. That we can ensure that people aren't judgy in helping people meet their basic needs, whether it's your gender identity, whether you're picking it up for someone else who needs it, whether you're a trans man who wants it, and doesn't want to talk about needing birth control, all of those reasons. I love how this Free the Pill campaign is allowing us to have this conversation and to really reimagine what do we need to rebuild or to shape in society so that we can reach our full autonomy and have all the full dignity that we want in accessing birth control, in accessing birthing care. And then there was also a question about abortion, also included. That is all part of this full spectrum reproductive health life. Thank you so much, Dr. Villanueva from New York, Jan Flint Robinson from LA, Victoria Nichols, also from LA, for this incredible, incredible conversation. For all you attendees who have been asking, yes, we generally do make these available online. Give us a couple of days and we'll try to save the chats and send those to you as well, because there are lots of valuable resources. Thank you for attending, and we'll see you next month for the next Free the Pill webinar.